Dr. Ryan, you are recognized for 5 minutes.
Thank you. Congresswoman Custer, Ranking Member Burgess, and esteemed subcommittee members, thank you for inviting me to participate in this important meeting. My name is Dr. Shawn Ryan. I'm a board-certified addiction specialist and an emergency physician. I take care of patients in Ohio. I'm also the chair of the Legislative Advocacy Committee of the American Society of Addiction Medicine, known as ASAM, a medical society representing over 6,000 clinicians who specialize in the prevention and treatment of addiction. I would like to begin by recognizing the phenomenal work Congress has done to advance crucial pieces of legislation and funding to address this crisis. It has made a life or death difference for many. However, we must do more to create a sustainable and robust treatment infrastructure, one that addresses addiction as the treatable, chronic medical disease that it is. To realize this vision, we must focus on 3 primary issues: strengthening the addiction treatment workforce, standardizing the delivery of individualized addiction care by rethinking our largest federal grant programs, and reforming payment policies and strongly enforcing mental health and addiction parity. Focusing first on our workforce needs, there are only about 3,000 board-certified addiction specialist physicians, according to ABMS, and in a recent survey in Massachusetts, only 1 in 4 healthcare providers report receiving training on addiction during the medical education. I know that I did not. For a country that prides itself on the medical care available to its citizens, this is simply unacceptable. That is why ASAM supports the Opioid Workforce Act, legislation that would provide additional GME slots to hospitals with programs in addiction medicine and addiction psychiatry. To ensure more healthcare providers receive basic training in addiction, ASAM supports the MATE Act, legislation that would require all DEA-controlled medication prescribers to have at least a baseline knowledge about addiction. Dr. James Baker, who is with us here today and behind me, has been a determined champion of the MATE Act in honor of his son, Max, whose life was unfortunately cut short in part because the medical community has yet to reckon fully with addiction. After or concurrent with the passage of the MATE Act, ASAM supports the passage of the MAT Act, legislation that would eliminate what would then be a redundant separate waiver to prescribe buprenorphine for addiction, along with a waiver of patient limits and regulations. Secondly, this workforce shortage is exacerbated by a long history of treating addiction in silos, as has been stated many times today. And available treatment is largely determined by local culture rather than nationally recognized standards of care. This must change. To that end, ASAM supports the State Opioid Response Grant Authorization Act with certain technical amendments and the addition of a new provision. This would strengthen the program by applying a Medicaid provider requirement included in both the bipartisan Ryan White CARE Act and in the late Elijah Cummings CARE Act. Such a provision would require certain grantees to enroll in Medicaid, ensuring that they can meet minimum standards, and grant funds are used as they are intended to pay for crucial services that cannot be billed to Medicaid. Investments above this foundational amount, however, need to be used more efficiently and effectively, and they should drive systemic and sustainable change. For example, Congress could establish a new supplemental grant program with conditions that require states and localities to adopt certain strategic policies. To qualify for this supplemental funding, states could be required to adopt nationally recognized levels of care standards for the regulation of addiction treatment programs. This would make oversight and payment more efficient and set baseline expectations for care as we have with the rest of American medicine. States could be incentivized to require health plans to use medical necessity criteria for addiction treatment as defined by national medical societies. And certain grantees could be required to offer all medication for addiction treatment. Over time, the largest federal grant programs in this space can be combined with a common set of modernized requirements. But let's be clear. We need these sizable grants because, to this day, mental health and addiction parity is not a reality. Payers continue to discriminate, and there is wide disparity in network use and provider payment rates. That brings us to the bills being considered today that will improve insurance coverage, specifically to those in the criminal justice system, which are the Medicaid Reentry Act and the Humane Correctional Health Care Act. Continuation of Medicaid coverage during detention and incarceration or reinstatement immediately prior to release will facilitate treatment continuity, retention, and save lives. ASAM is proud to support these bills. In conclusion, ASAM is actively building, implementing, and advocating for the tools and resources to secure a solid and sustainable foundation for addiction treatment in this country. While change won't be easy, it is both necessary and worth it to end the suffering being experienced across our nation, in our communities, and by American families. Thank you, and I look forward to your questions.
Mr. Ryan, are you aware of any estimates on the percentage of those who suffer from substance use disorder that become involved with the criminal justice system at some point and with either mental health or substance use disorder?
Absolutely. Thank you for the important question. Statistics show as high as 50 to 70% of individuals in the incarcerated population in any way, shape, or form have mental health and addiction. And in many locations where opioid use disorder is the most pervasive, there are places seeing as high as 75 to 80% of their justice population involved. So I've actually worked a fair bit with an institution that does jail health care across the state of Ohio and other areas, because I recognize that in this country we are not disconnecting criminal justice involved and substance use disorder probably ever. And so it's really important that we do speak to these transitions, and I can tell you firsthand in taking patients on at our treatment centers right out of criminal justice setting, the transition is quite hard, and we do really need to work to improve that.
So are there any estimates suggesting how many more could receive MAT in jails and prisons if such treatment was widely available?
I cannot say that I've seen an estimate in regards to what these particular bills would, how much it would increase the access to medication-assisted treatment. I will tell you in those localities where I've been involved that the sheriffs have been very supportive in doing this, and then we've seen the estimates as you described in Rhode Island. If we put a pervasive and sustained effort to deliver the absolutely necessary and evidence-based treatments such as MAT to these justice-involved individuals, they will do better.
Thank you very much. I appreciate it. And that's certainly been our experience in Sullivan County and now in Merrimack County in New Hampshire, where the recidivism rate dropped from as high as in the high 50%, 58%, all the way down to 18%. So I don't care if you're left, right, or center, that's a savings of tax dollars if we can get people back to the community, going to work, taking care of their families, and living in recovery. So thank you.
How do you think the addiction specialists would best be used if we were to improve and increase fairly dramatically the number of addiction specialists, which, as we've said, would also be trained not just on substance, I mean, whether it's alcohol, whether it's drug, whether it might be other addictions, addiction just generally. Can you just share with us how do you believe it would make a meaningful impact on this significant challenge?
Absolutely, a couple of points. So I'm board certified in addiction medicine, as those of us who are not in opioid medicine. So we're broadly trained in all of the substance use disorders, understanding that alcohol still has a huge impact on our society, and that we have to understand how to address that and every other substance, so that when drug use transitions to methamphetamines, et cetera, that the workforce is trained to manage any substance use disorder that becomes the topic of most importance at that time. So I just wanted to make that point. Also, we do have a system of care in this country for specialists and primary care to interact through different mechanisms. So the way that I would probably put it, Representative, is that specialists like myself should be taking care of the sickest patients. Not all opioid use disorder patients need the highest level of care or the highest trained specialist, but many do. And so we have these systems of care in place for chronic disease management. We should simply reflect back to those, as so for diabetes, so that and again, diabetes best managed the same way in a holistic model for patients. We should really parallel those types of systems of care and use those trained addiction specialists in that way.
Besides residencies, do you believe that our med schools and the education, higher ed institutions are doing enough relative to addictions?
Enough is a loaded question, I guess, a little bit, but no, I don't believe so, actually. In my personal opinion, I feel like there's more to be done. I've spent thousands of hours myself educating, medical students, residents, and I'm sure that others on the panel have done the same. I do believe we are behind the 8 ball on that, and I would say with the workforce at hand, we are also undereducated in relation to the disease of addiction.
Thank you, and with that, I yield back. Thank you all for your work.
Dr. Ryan, I understand that you too are an emergency physician and you're also an addiction specialist, correct?
Correct.
When there isn't long-term treatment on demand, how important is it to have this bridge of care in the interim?
It's very important, and thank you for the good question. I would say 2 things. One of which we've worked very hard in the state of Ohio where I practice to develop treatment on demand with ready access to medication-assisted treatment. And in some areas of the state, we're there, but in most parts of the country, we're not. And so I said, I would say that second point is, given the safety profile of buprenorphine, that what you're proposing makes sense to me, and I would support it, and so would ASAM.
Thank you. And as an emergency physician, what is the practical implication of this current restriction?
Well, the practical implication, as you know, emergency departments are very busy across the country. By and large, it's more common than not that they're overwhelmed. And so when you add this increased burden of a patient having to come back, not only is transportation for that patient an issue, it's almost always a big issue for patients with opioid disorder, but you burden the emergency department with more unnecessary visits for the simple administration of a very safe medication.
What would you say the return rate would be if you're in a rural area and your emergency department is quite far from your area?
I would say it would be very poor. I cannot quote a specific statistic. I'm not sure if anyone else on the panel is aware. I've not seen such a study. But knowing the return rates we have on a second day of admission for outpatient programs, it would
So
be
they
much
would be
worse.
lost to follow-up. They might receive the first dose, but then take an incomplete 3-day course.
It would seem that would be fairly common, yes.
Okay. So what are the implications of reversing this restriction for the provider? And in your experience, would this lead to greater rates of success for patients trying to access long-term treatment programs?
We do know from some studies that emergency department initiation of medication-assisted treatment with the appropriate transition to care can lead to substantially better retention rates in treatment, recovery, and lower rates of relapse.
So this is evidence-based programs that actually work to improve success and compliance as a bridge into long-term treatment with successful treatment for opioid misuse disorders, correct?
Correct.
Thank you. I yield back my time.
Thank you.
Have you encountered burdensome prior authorization processes or denials from private insurance when you try to get your patients the mental health and substance abuse care, both medication and services that they need? Dr. Ryan?
Thank you for the question. So I was actually the chair of payer relations in my past tenure at the American Society of Addiction Medicine, so a lot of insurance interaction. I would say that there are substantial utilization management techniques, such as the one you described, prior authorization, and other efforts to block access to care. They can be inadequate networks, could be inadequate payments in many cases, whether it be commercial or Medicaid. And so there are many obstacles to accessing appropriate reimbursement for good mental health and addiction care. There's also a lack of following of the science or national standards, so they'll often have their own criteria, may or may not be something that is nationally recognized as a standard. And so in finality, I would say the need to hold insurers accountable to the science and the evidence
Is Medicare or Medicaid different with regards to prior authorization for these types of claims?
So it's state by state in my experience, with Medicaid specifically, obviously. Medicare, coverage for opioid use disorder is a new thing, as was talked about earlier. And so I really don't know that we have an answer to that last part yet. But for Medicaid, it's state by state variance.
Is there something that if you were up here, you would have asked that we didn't of the first panel?
I would say actually how to better enforce parity is probably the number one thing that we deal with, because that would actually answer some of the questions you just asked. That if we were actually performing the oversight and regulation and adherence to parity, we wouldn't be having a conversation about a safe and fairly cheap medication and prior authorizations.
Yes?
Is it more training good, or is it more training just superfluous and it doesn't matter, we need to push more stuff out and get it out there, even though Ms. Rizzo has testified that there's harm that's potential from some of these medications?
So I would comment in something that was in a previous session when you all are out, which is basically we have parallel paradigms of this type of training, meaning as an emergency physician, I went through a very rigorous training program in emergency medicine at the University of Cincinnati and had wonderful NPs and PAs who came on board with me that may have been trained in family medicine, but because I had the upper level of training, was capable of bringing those folks along and educating them. So I would draw that parallel in saying that I think we need education at all levels. In fact, that's why ASAM supports the MATE and the MAT Act together in order to increase education.
Right, but in some states, as you know, there's not the in Texas, there is a supervisory requirement. I don't know about Ohio, but some states there is not. Understood. And that is what I know Dr. Bouchon, when we had those hearings, he was concerned about. He's a cardiothoracic surgeon. I think it's something that we need to bear in mind, and we're being asked now to extend the program before its expiration. We have a report due. I just think we ought to evaluate the report before we make a new decision. So thank you, and I'll yield back.
Thank you.
Now, Dr. Ryan, can you explain briefly how the current waiver system limits access to care, particularly for the 1/3 of Americans, largely in rural counties, who don't have access to a single waivered provider?
I think so. So I guess I would summarize by saying there are many barriers to access to care for medication-assisted treatment, specifically buprenorphine, and that this is one of them. There are also stigma, reimbursement challenges, et cetera, but in kind of in totality, it creates quite a barrier for folks to access treatment.
Thank you, everyone.